Hello, everybody. This is Shrutaraj Chaudhary from Pacific Northwest National Laboratory. It's a collaboration work with Dr. Susan Thamang's group at Stanford University and also with Virginia Tech and Johnson Labs. So we have been on looking at the COVID-19 datasets from Stanford Hospital, and especially looking at first 9 months of the COVID-19 data from January to September. And we have been focused on developing predictive models for various quantities of interest. One of the metrics that have really drawn our attention is the length of stay of patients. Length of stay can serve as a proxy for severity for the patients, and if you look at the chart on the right side of the screen, you'll see that there was a significant variation in the length of stay for the patients who had severe conditions. So this motivated us to think about or understand the fine-grained factors that influences the length of stay for different classes of patients and how it changed over time. The data set that we have worked with has three components. The first one is the diagnosis codes and the drug codes. We refer to those as structured data. And then we also have the clinical notes. And we also have the knowledge graph that is composed from both the OMAP ontology as well as other data sources that provides mapping between a drug code and its category, associated categories. So we try to look at the evolution of the length of stay month over month, and we try to look at the association between the length of stay and different single variable analysis. So as an example of the univariate analysis, this is a chart that shows you the variation of length of stay as a function of different risk factors. And what you could see that, well, there are three factors. The top three has a dominating role in determining what are the most severe cases are. But beyond that, we couldn't see much or glean much of the low-level understanding or more fine-grained understanding. This motivated us to higher order relationships. By higher order relationships, I mean sets. This could be a set of comorbidities. This could be the set of drugs that a patient is given at a point of time. And so what we further focused on was finding the frequent sets of drugs, diagnosis codes, or drugs that occur in the data set. So what you're seeing is that the graph you're seeing on the screen here, the green nodes represents patterns of comorbidities. So for every diagnosis code, we mapped it to a category of a disorder category, as we find in the OMAP ontology, or we could map them onto the system of organs. And for the drug codes, we can also map them to a class of drugs as well. So given this, we can look at the association between the patterns of different comorbidities and the treatments, or the set of concomitant drugs, if you will. If you also see that this is a weighted graph, which means that, and the age weights here represent, given a green node, a comorbidity pattern and a treatment pattern, or the associated drugs, the age weight represents the median length of stay for the patients who had that comorbidity and received the treatment. So by looking at the shift in this graph structure over time, we can gain some understanding of how the length of stay for the patients with certain comorbidities have changed. Preliminary findings from the study. So what you're seeing here is each of the column represents or is associated with a particular comorbidity. The y-axis represents the median length of stay, and the x-axis represents time, which is in this case is month over month. So a chart coming down, which is like the case for column 1 and column 3, indicates that the treatment, there was improvement in the effectiveness of the treatment over time. The chart staying flat suggests that there is probably not significant improvement, but not much deterioration. Whereas which is the case for column 2 and 5, but for something like column 4, where the length of stay actually went up as the time progressed, which indicates that either for some reason the treatment was not, the community has not converged to a good treatment or treatment protocol, or there were more cases that have started coming down in a later point of time and was not seen before. So right now we're in the progress of validating these findings on a newer and a bigger version of the data set. Our original data set had 450 patients and was till September to October, and the newer version at the end of the year almost has tripled the number of patients due to the late surges. So that's all I have for you. Thank you for listening.